Welcome to Chapter 4, which is about secondary databases in pharmacoepidemiology. This is going to be a short overview of the chapter, and this is coming from your reference book, Understanding Pharmacoepidemiology. In this chapter, we will go over 5 points of the chapter, which are collecting data for pharmacoepidemiological studies, the types of secondary databases, defining outcomes in secondary databases, measuring drug exposures in secondary databases, and special consideration when you're using secondary databases. So number one is collecting data for pharmacoepidemiological studies. There are two types of data, either a primary or a secondary. And basically the difference between the two, a primary database is the one that is collected by the researcher for their specific study. So the data is collected prospectively in real time for a specific purpose. And then usually the investigator developed their own instruments, their own questionnaire, targeting the variables of interest, independent and dependent variables, with a specific protocol on how to go about collecting the data. Probably there will be interviews, there will be maybe phone calls, there will be probably data abstraction from medical records, etc. Whereas a secondary database is using a database that already exists. The data is already there. It was collected for some purpose, some reason, and the researchers come and use that database for another purpose than its original purpose. And so that's basically the major difference between primary data and secondary data. Not to be confused with primary and secondary literature. These are very different concepts. So here are some list of advantages and disadvantages for primary data source. An advantage of primary, high level of control of type and amount of data obtained for the study subject. Since the researcher themselves are collecting the data, they make sure of what kind of information and how good of quality they want to collect to get. Data can usually be validated by the investigator. So, a very simple example, you may ask somebody if they suffer from a a certain disease, let's say hypertension. You may measure their blood pressure, for example, or they ask them to report their weight. You may actually ask them to step on a scale and measure their weight, for example. This advantage can be very expensive, expensive, especially if sample is large and detailed data collection is required. Um, you can think about how much it will be difficult to collect a large amount of data from one single person. Sometimes they do it, and it might take them hours, like 8 hours of interviews to collect all the types of data needed, which is very hard to do and not easy and not feasible. Often requires long time periods to account for, and subject response or follow-up period also is a disadvantage. However, for secondary databases, the advantage is typically less expensive than collecting new data. Obviously, for obvious reasons, the data is already there. Large samples and follow-up. There could be someone that already did the follow-up, somebody that has been collecting the data for a very long time. For مثلا, governmental agencies might have large amount of information for many, many, many years that otherwise you cannot have access to. May allow the study for rare conditions or drugs كمان لأنه it's a very large database. The disadvantage, lack of control over data included from study participants. Since the data has been collected for a purpose that is not the one for the study, you have no idea or you have no control of what kind of variables have been collected. Validation may be difficult or impossible, although certain quality checks can be performed. Um, if you think about it, if the data has been collected for many years, sometimes it will be very hard to go back and check if the patients 20 or 30 years ago really had a certain type of an outcome. But in certain instances, it may be possible. Potential problems associated with coding, if there is some error in coding or there is a change in the coding, all of this has to be accounted for. So by relying on secondary data, researcher does have a lot of control over the quality of the data collected. That's why researchers rely on sophisticated statistical technique or study design to maximize internal validity. So maybe later on in different chapters, we'll go back to this concept of statistical techniques. When we come to the quality of the data or things that are threatens the internal validity of your study, there are different techniques that can be done to reduce the threats to internal validity. Some of these things can be done at the design level, and this is typically done when you have the primary data, yani the study you're running actually is collecting its own data, but there are other techniques that are more related to controlling for variables and doing some sort of propensity score matching, for example, and that could be done at the level of the data. And we will discuss this when the time comes. So the types of secondary data source. We're just going to go over the major types. We're not going to dwell too much on them. It's just a very brief introductory. So, number one is automated healthcare databases, transactional databases. Think about it. Every time a payer is making a payment for a healthcare service, whether it's buying a medication or going to the hospital or seeing a doctor, if that patient is covered somehow by by an insurance or an SSSF or the government, there should be a paper trail for that payment, and therefore you should be able to trace back what kind of service was done, and in fact you will be collecting a huge amount of information, and this is actually done. The data is actually collected. So, transactional databases, data collected automatically whenever a patient encounters the healthcare system and some type of event occurs, such as hospital admission or a filled prescription. So a filled prescription, you can think about it at two levels. A provider might prescribe, so هون في عنا at the level of the doctor, and the patient actually going and getting their prescription. So that would be at the level of the pharmacy. The reason I'm mentioning that is because I wanted you to think about how you may have different levels of data for the same kind of information, and then you may need at one point or another to link this data together, which is a point that we'll come to at the end of the lecture, and that has its own challenge. Then created, so these transactional databases created to facilitate the reimbursement of healthcare practitioner whenever service are provided to a patient. So that's the reason we have these databases. But these, as I mentioned, it gives you a huge amount of information that can be used for to answer a lot of research questions. So the study using these sources have increased generalizability and allow the study of effectiveness rather than efficacy as studied in RCT. Okay, so we already talked about generalizability in the previous lectures, and the concept of external validity and how it relates better to effectiveness rather than efficacy. And because it's what is happening in real life, then it gives you a better idea than RCTs. Limitation of transactional databases is whether they actually reflect what actually happened from an exposure and or outcome standpoint. So, for example, it captured prescription and not actually taken the drug, which leads to misclassification. Um, so, as I said a minute ago, if you're looking at the data right from the standpoint of the physician that prescribed, that doesn't tell you if the patient actually took the medication, and therefore that may lead to misclassification. And misclassification is an interesting concept that we're going to visit again and again. This is where somebody who is exposed is labeled as non-exposed and vice versa. So this is called misclassification at exposure level, or somebody who has the outcome is misclassified as not having the outcome, and vice versa, which is a misclassification at the level of the outcome. So this could happen, for example, if you're looking at hospitalization and you're looking at the amount of how many medications a patient is billed, the number of medication might not reflect what is happening because maybe they're overbilling, or maybe he was billed the medication but ended up not taking all the medications and things like that. The second type of secondary databases in electronic medical records. The implementation of electronic medical records is relatively low among hospitals and outpatient medical practice, but is growing. Um, it's growing exponentially, especially in Lebanon with the introduction of Epic, I think, at the AUBMC, and something similar to that at Rizal Hospital, where you're linking all the electronic records together. These systems generally involve immediate electronic access to information about care provided to individual over time. The information contained in EMRs can provide a wealth of information for research purposes. And this is true. If you ever had a chance to sit with someone who has access to electronic medical records, on the spot they can retrieve مثلا X-rays or MRIs or blood tests, even if they were done years ago, they will be able to retrieve them, and you can appreciate the importance and the wealth of information that can be provided through these records. The advantage of electronic medical records, the efficiency offered over manual chart review, typically offer a greater level of detail than is available in data from administered claim or patient or provider questionnaire. The latency period between the generation of the data and its availability for research can be minimal or non-existent. So as I said, by just few clicks, you can get the data, and the data will be of good quality. The limitation, the data contained EMRs are typically quite complex given the longitudinal nature and the volume of information. Which is true. Sometimes, yani, the advantage becomes a disadvantage. You get so much information that it becomes harder for you to just extract one point of information that you are interested in. The lack of standardization of the actual data structure across EMR's vendors. مثل ما كنا عم نقول, you may have Epic, you may have another one and a different one. And then if your study is involving multiple hospitals, getting all this data to speak to it together is a problem. And this is true not only in EMRs, but any kind of different databases that are different using different structures. حتى within the same hospital. So sometimes you are interested in combining information. Like one time we were looking at emergency records. So you have the emergency admission, you have the pharmacy, you have the admission, you have the billing, and we were trying to combine all of that. But however, they're not all set up in the same structure, and that is a very challenging thing to do. Number three is national surveys or databases. Some governments make selected data available for research purpose. عندنا نحن بلبنان في عنا يمكن the I'm trying to remember the name. It's something like AZA, something like هي مديرية الإحصاء, which follows the رئاسة الحكومة, and they have a lot of data collected by surveys, things like on number of cars, number of TVs, number of households. And if this data is available, then you can use it to part of a research question or part of a project. These sources can provide a great deal of information and frequently have extensive documentation and user communities that can be helpful by providing a great deal of informal support through direct contact and previous publications. يعني مثلا you could be interested in knowing the distribution of elderly in Lebanon, so that to reflect on the number of elderly admitted in Beirut versus number of elderly admitted in another area. Well, if you want to know the national number of elderlies, that would be available in national surveys or databases. Databases مثلا ممكن يكونوا I think registries, kidney disease registries, cancer registries وهالقصص. So in the US, they have a number of registries and databases. Um, you probably have already heard of Medicare and Medicaid data, administrative claims data for patients enrolled in Medicare or Medicaid plans throughout the United States. Another one that you're aware of because we already mentioned it is the Adverse Event Reporting System. This is the FDA repository of adverse events from approved drug and therapeutic biological projects. في كمان the one for vaccine, which I think we will mention in the next slide. So really, that takes us to the fourth type of database that is available in the adverse event reporting system, and we talked about this. We touched based on this when we were discussing the reporting adverse event and how they are used for safety signals. So reports of adverse events associated with or thought to be associated with the use of drugs can be an important source of data for medication safety studies. In the United States, adverse events data are gathered by مثل ما قلنا المدواتش اللي for FDA. Although the FDA conducts its own analysis, data are made available for external analysis through the Adverse Event Reporting System database. ومثل ما قلنا there is also the vaccine adverse events reporting system which is run in cooperation between the FDA and the CDC. So they do run their own analysis, but the data is out there. So many مثلا PhD students, they do their PhDs using these available databases because they would be addressing specific questions um, that the FDA might not be interested in looking at. And so other sources, other data sources that do not fit into the previous categories هن مثلا RCT. So كيف RCT? You might tell me that RCT is a primary database. You would be right if, I'm sorry, you would be right if the RCT is actually, if the data of the RCT is used for the primary research question. However, if somebody comes later on and says, okay, well, you know, you collected this data, let me use it to answer a different research question, then that would become a secondary database. Also, epidemiological or observational studies, so any kind of study that has collected data and somebody is using that data for a different research question. Okay, so they're looking at something totally different from what it was originally intended. It becomes a secondary database. Number three, registries, when we and kind of like mentioned that. So for our city, we have an example, and this is coming from the lipid study, which is the long-term intervention with pravastatin in ischemic diseases. So it was a double-blind RCT examining the effect of pravastatin on mortality due to coronary heart disease. There was a follow-up of 6 years. So if you only look at pravastatin and the heart disease, it's not a secondary database, it's a primary database. So let's continue. Patients were randomized into either receiving the medication or the placebo. However, although the original article focused on the use of this statin in coronary heart disease, and different authors came and used the data, so the lipid study, to look at the statin and bone fracture. Okay, so they're using data already collected for the lipid study, but this time for a different reason, and therefore it becomes a secondary database. Okay. So other epidemiological studies has suggested so far that statin, there is an effect on statin on bone fractures, which risk changes from no effect to 70% risk reduction. So the studies were saying that the use of statin has a protection on bone fracture. Okay. So what happened is that when these people started looking at this question using the lipid study, that's what they found: 50% increase in the rate of fracture requiring hospitalization among those receiving the statin when compared to placebo. And when an analysis was repeated to include those with bone fractures that do not need hospitalization, it showed a 4% reduction in the rate of fractures among those taking the statin. However, both analyses showed no statistical significance. So I'm hoping that you're appreciating the importance of this. Other studies that were not RCTs were suggesting a protecting effect. These people came in and used an RCT and looked at the same idea, halostatin and bone fractures are related, and basically what they found that there was no statistical significance associating the statin and the bone fracture. So what did the study conclude? Insufficient evidence to support the hypothesis that statin can be protective against fracture, and that's what we just said. What are possible causes of the lack of statistical significance? And they talk about confounding. The idea of confounding is also an issue that we will address in one chapter. We already have seen it in PHA 421 briefly. Here we're going to talk about it in more details because that is one of the major concepts that is going to come again and again whenever you're looking at any kind of research, RCT or epidemiological studies or health-related studies. The concept of confounding is going to be present. Okay, um, so that concludes number two. Let's move to number three, which is defining outcomes. Remember, any pharmacological study or any study, usually في عنا exposure وفي عنا outcome, right? Remember, the exposure is the independent variable and the outcome is the dependent variable. So usually, what are the outcomes in pharmacological diseases studies? So it could be the disease or condition. It could be a medical procedure. So, like being in a certain condition, will it lead to a certain procedure مثل hemodialysis or mechanical ventilation. هلا عم نحكي mechanical ventilation, especially with COVID-19. It could be one of the major outcomes. Or maybe there was a need for laboratory test values. So looking at what happened to blood, what happened to HbA1c, etc. or the use of particular medication, including medication adherence. So that also could be an outcome. All right, so one of the outcomes could be looked at discharge from hospital. Its simplest discharge analysis looking at the discharge either live or dead. That's a very simplistic way to look at things. Well, remember, you will have that on medical records or discharge records. So come in, it's going to be a secondary database. Or more detailed, you can look at, was the patient discharged to a nursing home? Was the patient discharged to home health care? Or was the patient discharged against medical advice? And all of these are considered outcome under the umbrella of discharge. For disease and condition, an important thing that you should be aware of or you should familiarize yourself with is the international classifications of diseases اللي هو ال ICD-10, and sometimes we may be talking about ICD-9 CM. ليش؟ لأنه more and more people are using the ICDs to record outcomes, medical conditions, diseases, حتى reasons of death, part of the ICD. And this is a systematic way of reporting outcomes that is unique or not unique, unifying all types of classifications all around the world. So if you have an ICD-10 or ICD-9 code, wherever you are in the globe, it means the same thing. So the ICD-9 CM or 10 for that matter is a hierarchical system in its nature. It's made of 4 or 5 characters in length and grouped such as the highest level represents organ system or disease process. So here's an example from your book. عندنا number 39 لحديت 459.9 is the circulatory systems, and then under that you can see that you have مثلا hypertensive diseases from 401 to 405, and then under that you have the essential hypertension and etc. You can appreciate the hierarchy there, and that makes it easy also for the researchers. So for the researchers, if they're interested with anything that is hypertension disease, then they would just within using the ICD code, writing computer algorithm, telling the computer identify any code between 401 and 405 and get them for me. All right, so it facilitates the work and reduces the error as well. Come in, another way to looking at the outcome is procedures and services by themselves could be an outcome. So like utilization of service may be an outcome, like how many times they were hospitalized, what was the length of their hospitalization, or the number of clinic visits, or the number of visits to the primary care centers, etc. هول بيعتبرون outcomes. مثلا some NGOs are interested in seeing how they're functioning, and one of the outcomes they look at is مثلا pregnant women visits to their to the gynecologist at the primary health care center. وبيكون عندهم guidelines مثلا she should visit 3 to 6 times during her pregnancies. So these have a lot of utility. Um, so measuring utilization may be as counting the number of days in a hospital, as I mentioned, determining whether a certain procedure was performed, for example. Sometimes the length of stay is important as well. مثلا, it could be positive, it could be negative, depending upon how you look at it. Yani, the longer you stay could indicate a bad outcome or maybe a good outcome. When dates are available, they can be useful to establish temporal relationship between the exposure of interest and the outcome. That I cannot tell you how much this is important. The dates are just an amazing key factor whenever you're doing any kind of research. Without the dates, you're going to lose the temporality. And I talk about temporality in the causation lecture, which is a key criteria, or I say key criterion for causality. And I may as well tell you right now that many times ما بيكون في dates. The dates are not going to be registered. Another type of outcome could be drug utilization by itself. يعني مثلا يمكن that condition led to a certain point where there was a need for starting a certain medication. The use of particular drug or class of drugs can be an important outcome in pharmacological epidemiological studies. Certain drugs can be used to identify potential adverse event and or medical errors. and you have examples. drug utilization pattern مثل ما we mentioned previously هيكون في chapter on that in terms of شو معناتها adherence شو معناتها compliance شو معناتها persistence. But if the data is there, then you will be able to calculate these concepts and utilize them and generate um, conclusions. So briefly here, very briefly, we're going to brush over these concepts very briefly. You will have the chance to look at them in a different chapter. There are types of how measuring drug utilization. في عنا شيء اسمه the defined daily dose DDD, the prescribed daily dose the PDD, and the days of therapy. So the defined daily dose, it's the assumed average maintenance dose per day for drug use for its main indication in adults, specific to a drug and route of administration. So there can be an oral DDD and a parenteral DDD for the same drug. Just going to move to the example. For example, a hospital wants to compare its use of ceftriaxone to the national average. The WHO DDD for ceftriaxone is 2 grams. So WHO has its own DDD recommendation out there. The hospital determines that it has dispensed 4,439.5 gram of that drug over the period of a year. During that period, the hospital accounted for 69,952 patient days, representing 14,692 patients. Patient day, yani multiply the patient by the number of days at the hospital. And this concept of patient day, we've seen it when we looked at, I think it was the incidence rate, okay, versus the cumulative incidence, right? All right. So what you can do is the total DDD is per thousand patient days for the hospital can be calculated. And we're going to look at the calculation. So you take the number disposed or dispensed, sorry, by the hospital, and knowing that 2 gram is the DDD by WHO, that gets you the 2,219 DDDs. You divide that by the number of patient of days times 100, and you will get to 32.1 DDDs per thousand patients a day. Okay, and this hospital specific value can be then compared to the average of the national or other hospital. Okay. Similar to DDD في عنا prescribed daily dose, this method is useful in that it can be calculated from the data at hand to reflect the actual average dose being prescribed to patients or from dispensing or ordering data reflective to national prescribing habits. مثل ما عم أقول, I'm not going into details here. I'm just looking at things very briefly because you're going to have a specific chapter looking at these things. Last is the days of therapy. It's another method which is simply counting the number of days that at least one dose of the drug was taken or should have been taken. Um, this method covers issue with different doses or required adjustment for renal and hepatic insufficiencies. So it overcomes this problem. It does not, however, take into consideration the actual dose of the drug. So that concludes number 3, and the number 3 was about the outcome. Now let's look at the exposure, and since it's pharmacoepidemiology, you're interested in drug exposure. So when you come to defining drug exposure, there are 2 important issues that you have to take into mind. The drug itself. So anytime في حدا عم ياخد دواء بدنا نفكر the drug itself or the classification of the drug, what class of medication, and how to measure that exposure. We kind of like addressed measure of exposure شوي قبل. But also there is the idea of which drug and what class of drugs. If you ever worked with a database on drugs, which I have been doing that for the past years, you would understand how complex that is. Because you have drugs that are equivalent and you have drugs that are the same active ingredient, drugs that they're within the same pharmaceutical class, pharmacological class, therapeutic class, and it's really a complex issue. So there are a number of drug coding scheme, And these drug coding scheme are very important. The most familiar coding scheme is the National Drug Code, the NCD. It's good at identifying the drug itself. However, it does not classify the drug automatically into its therapeutic class, for example. Other schemes for coding the drugs, see the American Hospital Formulary Service Pharmacological Therapeutic Classification System, AHFS, and there's the WHO's Anatomic Therapeutic Chemical Classification System, the ATC. And over here you have an example of the NCD, the ATC, and the AHFS. Again, if you're dealing with a very large database with a lot of information, these can be very helpful in making the data more manipulable, more easier to analyze and extract information. Unfortunately, much less than the ICD, the coding of medication is utilized. Yani you might see databases في عندهم ICD-10, ICD-9. However, with medication, it's going to be much, much rarer. And I'm talking out of experience. I've dealt with a lot of databases coming from primary healthcare settings where we looked at outcomes, we looked at medications, we looked at disorders, whether it's communicable or non-communicable, etc. For outcomes, we do sometimes come across codes, the ICD codes, more often than not. However, for drugs, it's all over the place. It's all over the place. بلبنان, we're not familiar with any kind of codings from my stand of view. Okay, so how do we measure drug exposure? Drug exposure can be measured in two different ways. So it's either a categorical, yani yes, so there's some level of exposure, or continuous, where you're going to actually give it a measure, a unit of how much exposure happened. If you're into the categorical, then it's one of two ways. Provide a certain description of the extent of the sample that is exposed to the drug, and you can also look at low, medium, and high classification. Um, Sometimes it's desirable to quantify the drug exposure rather than just a yes and a no. So the first method uses information about the actual amount of the drug prescribed. The amount of drug can be assumed over the study period for a given patient to calculate the total exposure up to the drug of interest. This same information could be used to determine the average amount of drug per day or the daily dose. So, for example, a patient with diabetes is taking metformin at a dose of 500 milligrams 3 times daily would have a daily dose of 1.5 grams um, of metformin. This type of information can be calculated for individual in the community or for hospital patients if the appropriate data is available. In some situations, information about the amount of drug prescribed or dispensed is not available. In these instances, drug exposure can still be quantified from the perspective of time. Okay, so like how long have they been taking the medication? So how do we do it? في عنا days on therapy method which we covered, وفي عنا the measures the length of therapy. So in addition to quantifying drug exposure, it's often useful to determine whether when exposure began. This is very important when the outcome must be determined to have occurred after the exposure to the drug. عم نرجع لفكرة temporality. Okay? And again, I cannot underline how much important dates are and things like that. However, I want to introduce a concept which we will see again and again, which is the index date. So the index date for drug exposure may be the date when the first prescription was filled for outpatient, or when the first dose was dispensed or administered for inpatients. هذا اسمه index date. An index date basically is the first time something happened. So for drug exposure, it could be the first time they ever came uh, encountered with the drug, whether it was through a prescription or taking the medication. An index date for the outcome could be when they were diagnosed with this outcome, or the first time they were hospitalized for the certain outcome. So, index dates are of paramount importance whenever you're dealing with research. So, special consideration when using secondary databases, and I think they're going to be straightforward. Um, same issues, some issues such as research approval by the local institution reviews or ethic boards are important regardless of whether primary or secondary data are being used. And even if you have a database that has been collected for a while, or maybe it's your medical records from your clinic or from your hospital, if you want to use this data to run a research question, like it's been done مثلا in some hospitals regarding oncology, بيكون عندهم a lot of patients, they're following them up, they're looking at survival, and they want to analyze the data, they have to get IRB. مع إنه the data is there, it is um, uh, well, usually it's not de-identified, but they should de-identified, etc. You must get an IRB approval. Okay. There are, however, special issues that are not typical consideration when using primary data. Two important هن أول شيء في عنا patient privacy والHIPAA. I cannot tell you how much this is an issue. Dealing with the privacy of patients, especially whenever you're dealing with databases or patients' records. يعني, a lot of times, researchers share data with names of patients which they should not, or identifying data like telephone number, address, and things like that. That should not happen. The author talks about HIPAA. HIPAA is a big act that was passed to protect people from being identified in any kind of research using their administrative, transactional, etc. data. Um, but I'm not, but it's still feasible. It's not like it's not feasible. The last thing that I kind of like touched upon at the beginning of the lecture is structure and linkage of data. Um, Unfortunately, we do not live in a perfect world, and different providers, hospitals, clinics, national databases use a different format of data. And therefore, although a lot of times hypothetically the data is there, the amount of work needed to make to link the data together is unbelievably hard. To the point that one time we were working with one of the health insurances, and we were asking the health insurance to identify people that had certain characteristics based on the number of based on diagnosis and hospitalization utilization. Between parentheses, you can see the importance of ICD codes home to find those that have these diagnoses. لأنه you don't want to do a misclassification, and also the importance of finding claim data, because that's where you will find how many days of hospitalization they had. And although it seemed very simple, they could not do it for us. Data is so much complicated. The setup is done in such a manner that if they were to do it, they would need somebody who is hired for that specific purpose. بما أنه this was a service that they were doing for the research project, they decided that it's taking too much of their time. What I want to just, يعني, all I'm trying to say is that just because data is there, it doesn't mean it's readily available. And on one hand, yes, the data is there, it's easy to get in principle, and you should be able to tap on this wealth of data. But at the same time, we lack the training of people that have data management skills, مش data analysis, data management. يعني the possibility of flipping data, turning data, changing from records that are multiple records for one person to multiple variables for one person, stacking data on top of the other, stacking data next to one another. That is really something that we need. And a lot of times, not only you need a lot of skills to do that, but you also need a lot of memories, RAMs, and softwares to support this kind of work. So you have this as an example where you have patient characteristics, laboratory data, pharmacy data, diagnosis data, and we're just, abstracting or merging or linking these different data sets to create a new data set for the study. But that is like a perfect world. That would be like very simple to do. In real life, things are much, much complicated. Um, so finally, the medical record number can be used to identify patients and the patient account number and some familiars, etc. So all we're saying that there is a one identifier that you can use to link the data together. Uh, that is هون كانت البيشنت ID, but sometimes you may have the name in one place which you should not. The patient ID أو مثلا the admission record number. يمكن الفارماسي يكون عنده a different numbering system, and it becomes very complicated. In conclusion, secondary databases هن databases that are already there and have been collected for other purpose than just your research question. Their advantage in they can have a wealth of information for a very large number of populations for things that you cannot address in RCTs. They reflect what happened in reality. You will get a lot of rare outcomes that you do not observe. So it has a lot of uh, uh, advantages. The disadvantage is that most of the time whole information are not available in one place, so you have to patch them up. Also, you may have a lot of missing information, or sometimes a few missing may cause that you lose more and more data. مثلا مثل ما قلنا dates, if you do not have, you cannot figure out which came first, and therefore you start losing more data. And that's it for this lecture. I tried to make it as brief and as simple as possible. The idea behind it is just to get you familiarized with the idea of secondary databases and how much important they are in pharmacoepidemiology. Hopefully, as we go over examples and in different chapters, we will come back to the idea that this study was done using secondary databases. Thank you for your time.